Thank you so much for joining us today. We'll be bouncing back and forth between myself and Sarah, and we'll introduce ourselves in just a moment.
So I think we've got a total, I'm looking at people joining wildly, going up toward 100 people across the country. And just to reiterate, Dr. Aldred and I are here on unceded Lheidli T'enneh territory in Prince George, and we're going to talk for about the next hour or so, depending on how it goes, about health humanities and unsettling colonial medicine. Neither of us has any commercial interests or conflicts to declare. And this is sort of how the next hour is going to unfold. We're going to take turns talking about how it is that we think through various components of humanities and trying to unsettle what is arguably a very colonized system, which is the current healthcare system in Canada. And we're going to sort of share stories. We're going to share theoretical researched evidence bases for what it is that we think about and do. We're going to have a couple of interactive exercises that maybe can hopefully just be done in your own places from coast to coast to coast. And we do hope to ensure that there's a little bit of time at the end of this hour so that we can all have some good time for questions and discussion.
My name is Dr. Terri Aldred. I'm a Dakas woman. I'm carrier from the Kazda Nation that's located just north of Fort St. James. And I'm a member of the Leeuw of the Frog Clan, traditionally known as the voice of the people and those who can make great transitions. I follow my great-grandmother Cecilia Pierre's line from the community of Tache, and my great-grandfather was Norman Prince from Nakasley, and my grandma was Shirley Schweitzer, who relocated to the Prince George area. And on my dad's side, which I traditionally didn't know much about, but I'm learning more, I actually have Cree heritage from the Treaty 8 First Nations, as well as Anishinaabe and Métis roots from the Red River Valley, as well as mixed European background. I am a family physician. I do outreach to First Nations communities in North Central BC for Carrier-Sacani Family Services. I work in the communities of Yukuche, Takla Landing, Skilatin, Notley, and Saigas. And I'm also the site director for the Indigenous Family Medicine Program. Thank you so much for joining us.
So now that you know Terry's voice well, I'll say that, first of all, I just, before we started, thank Terry so much for being willing to do this webinar with the NCCAH and with me. In the past, I've given webinars, and it's just me standing here talking to a computer. So it's so beautiful and lovely to have a friend and somebody I think the world of sitting beside me. It makes this all the easier. My name's Sarah DeLeo, and as those of you who might have Dutch heritage will be able to ascertain quickly, my dad was actually born in the Netherlands and came over as a teenager with my opa and oma from Holland as part of the largest migration of Dutch immigrants to Canada that took place just after World War II, after Nazi-occupied Germany. My Opa was in a labor camp in the Netherlands and under Nazi-occupied Germany, and came over with, as I said, my dad, my aunt, and my uncle when they were teenagers. And they settled in the Cowichan Valley, just on the edge of the Cowichan Indian Reserve, where my mom now lives. But we moved to Haida Gwaii when I was very young, so I grew up on Haida Gwaii, and I graduated from high school in Terrace, which is another small northern BC community, Tsimshian territory. And today I divide my time between unceded Lheidli T'enneh territory in Prince George and Syilx territory in Kelowna. I don't know as much about my mom's history as I'd like to. It's something that I think in sort of patriarchal lineages is often subjugated, as the male lineage of my father's lineage was the last name that we took. But I do know that my mom was born in Ottawa. She was the child of military family. So she was kind of what was called, I think, a military brat. And they moved across Canada when she was young to Victoria, which is where I was born. Those are, I think, sort of putting into place, as Terry and I have shared with you, the important stories that define us all. And in some ways, as I've come to know, when we are working in the area of Indigenous people's health and the conversations about cultural humility and cultural safety, it is really important to share exactly the kind of stories that we just shared. So if that can be in part an exemplary from the start of the conversation, that's an important piece of knowledge that, especially with Terri's offering of her lineage and connection to this conversation, we should all, I think, take note of.
Absolutely. And to go along with that, I would encourage you all, if you don't know the traditional territory that you're currently on, it would be worth to look it up just to familiarize yourself, as well as maybe the traditional territory where you grew up. And that is actually one of the TRC's, the Truth and Reconciliation Commission's recommendations that we'll probably talk about a little bit more later. Today, what we hope you'll leave with is inspiration about using arts and humanities in health practices and education, concrete ideas about ways to inspire interest in Indigenous well-being, understanding Indigenous stories about practicing medicine, and to share a little bit of resources and ideas with you.
The cover slide covered it, but just because I'm a huge fan of Indigenous art globally, a lot of the images that you're seeing, we do credit the artist, just so that you're aware of whose images we're gesturing toward. But a lot of the images are by an Indigenous woman named Lisa Boyven. She's on the cover slide of this presentation, so do go back and have a look at her work. She is an incredible Indigenous artist whose visual imagery and her writing and her TED Talks speak about ways that Indigenous modes of well-being and Indigenous health perspectives can be merged in sort of a holistic and win-win situation with more Western bioscientific ways of understanding medicine and healthcare practices. But also in gesturing toward the incredible ways that Indigenous people think about and work in the healthcare system, we'll now move over to some stories from Terri.
So in order to be as trauma-informed as possible, a lot of the stories I'm going to share is going to set the stage of what it's like being an Indigenous person accessing medicine or an Indigenous person working in the healthcare field. And so just before we do that, if people would like to have a check-in with themselves, see, to connect to time and space, to land wherever you are in the present moment. And an easy way to do that is to sit up tall, maybe close your eyes if you're able to. Don't do that if you're driving. And just connect into your heart center. You may want to put a hand onto your heart, and that could be on the left side of your chest or in the center of your chest, wherever feels good. And just take a deep breath in and sigh it out. And just connect into the here, into the now. And just see if there's anything that you can put away for the moment, whether or not that's your busy to-do list, wherever you need to be after this presentation. See if you can just find some space to put it away. And just open yourselves to the stories I'm about to share. And I just ask, though, that you really be kind to yourselves. And so if you find that potentially triggering to hear some of the things I'm about to say, that you feel like you need some space or some time, feel free to mute this or take a little walk and come back when you're ready. So just be really kind to yourselves. Or maybe take some notes to journal about later, like notice if maybe you have a lot of tension that comes up, or anger or sadness, and just take note. I encourage you to reflect on that either now or later. So I was going to share 3 stories about 3 different times of my life. So the first one, as depicted by the picture on the top left part of the screen. So that's a picture of my grandma Shirley Schweitzer, who has returned to the spirit world now. And this is a story about many, many years ago, before I was born, but it's a story that really impacted me when she shared it with me. It was a time when she had what we call acute abdominal pain, so sudden onset of abdominal pain. She was in town already, she was at the bingo, but it was bad enough that she actually left the bingo to go to the emergency room, so it had to be pretty bad. And my grandpa went with her at the time, but it seemed to be taking hours for her to actually be seen by a doctor, and they lived out of town and had animals and such, so he had to leave to go tend to them. And she waited in the emergency room for something like 18 hours. It was for the rest of the day, all night and into the morning. And during that time, she heard numerous conversations outside the curtain about her and about how she was drug seeking, how she, her pain wasn't that bad, and people like her are in here for this all the time. And so by the time it came to the morning, when my grandpa checked in on her, she just left. She figured, she wasn't going to get the help that she needed. And she refused to go to the emergency ever again. Thankfully, she did have a family doctor and she did get care through the clinic. When she became acutely ill, about 25 years later, she still refused to go to emergency. So she was having recurrent bladder infections that she was receiving treatment for, but they were so consistent that the medicines just weren't working. And when my cousin checked in on her, she was so drowsy and weak that she couldn't fight my cousin off when my cousin insisted to bring her to emergency. At that point, it was found that she had a fistula to her bladder from a tumor in her bowel that she would die from about 3 months later. And so I share this because this was the kind of stories that I grew up with. So this was shared from my family, from my friends, and my community members. And these stories were shared in order to warn each other about what we might face if we tried to access care, and that if we can, it would be best to avoid it. And were ways that we were felt to be segregated and isolated and oppressed from the rest of Canada in care that they may receive in a different way than us. And it also made me passionate because I wanted to give back to my community. I wanted to see us be healthier and to thrive more. And I really wanted to change that narrative. And so fast forward, so the middle picture is me. It was a picture taken in medical school for an Indigenous mentorship project. And so I definitely didn't know I was going into medicine. I didn't know any other Indigenous doctors growing up. And I was actually more in a trades route before being really encouraged by mentors and teachers of mine to consider medicine. And it honestly was something that I never thought would be possible for me. And I literally laughed at them the first time they suggested it. And when I got in, I was completely terrified. But one of the teachings that I grew up with were the pride of one is the pride of all. So it's not about me, and I have an onus to become the best person I can, because I don't just represent myself, but my family, my community, my nation. And the other one was that if fear is the only thing holding you back, then that's your path, because that's your edge. That's how you will grow and become essentially a better person. And so when I really checked in about it, fear was the only thing. And so I knew that that was my path. And I've had many conversations with the creator since then about why he thought that this was my path. But at the time, I knew it to be true. And, initially it was the best thing that ever happened to me. I was given all these opportunities to go to conferences in Ottawa. At that point, I'd never even been on a plane before. I met all these amazing human beings in my medical class that already did so many interesting things, but very few who really came from a background of poverty and addiction and abuse like I did. And so I really had a feeling of not belonging. But I got connected with the Indigenous Physicians Association of Canada and found all these really strong, amazing Indigenous mentors, both at the U of A, but also provincially and, back home, as well as across the country. And so that really kept me going. But as my medicine journey went on, some deficits in the training became very apparent on the receiving end, I guess, of shame-based teachings, particularly in my clerkship. I was really shocked because my knowledge of what Indigenous healers, how they trained, was so different, and that, you were trained from usually quite young, and the whole point was for you to be the healthiest and most vibrant version of yourself so that you can go out and give that to other people. And so I was surprised that a lot of people in the traditional medical system or Western medical system were burnt out. They were constantly run off their feet. that they were very self-sacrificing, that they often neglected their own health and well-being, their families, and it just wasn't the model that I thought of. And as a result, I became a wounded healer. So I became burned out myself. I became bitter, angry at the system. And it really reactivated actually a lot of my childhood trauma. But being, a good student, I just stuck it out. I just persevered. And I reassured myself that once I was, got through the system, that things were going to be better. But unfortunately, as I go into my third version or part of my life story, there's a picture depicted on the lower right-hand side of the screen. So these are two young girls from one of the communities that I go to. I do have permission to share this video. And actually quite sweet because the older one's teaching the younger one how to use the stethoscope. And so my goal in medicine was to come back and serve communities in their communities. And I'm very honored and privileged to the fact that I do that in my work. But unfortunately, on a very regular basis, probably at least once a month, if not more, I get feedback from community members about their experiences when they seek care at the emergency room or walk-in clinics and other service providers. And sometimes I'm the one who has to send them to emerge because there's something going on that's critical enough that I can't take care of it at the health center or through telehealth. And the response I hear is, that's where our people go to die. A colleague of mine, Dr. James McCocus, he did his resident research project that had that same name because that's what his community shared with him when he asked them about accessing care at the local hospital in his traditional community of Saddle Lake First Nations. And unfortunately, that's still the narrative. I mentioned that I'm the psych director for the Indigenous Family Medicine program, but I'm also an alumni of that same program. And over this past year, I had reached out to do a couple of alumni calls because I had some informal connections and feedback from some alumni saying that they really needed some connection back to the group. And what they shared, what they struggled with the most was the fact that at different times, it was mirrored to them how hard it was to not be racist in a racist system, and how in different ways of certain actions or certain words that they used, they weren't able to see were racist. On reflection, reflected the systemic racism that they worked in, and how hard that was for them because they went through the Indigenous Family Medicine program. They're people who are very reflective, very in tune with reconciled medicine. But when they have colleagues and systems that support racist medicine, that windows away at you, and it's sometimes easier to go with the status quo. And that was the biggest burden that they were carrying. Just recently, we do sharing circles in my residency whenever we get together in person. And one of my residents shared a story that I would like to end with about an elder who was not feeling very well. He had chronic leg pain and peripheral vascular disease of both legs. But one of his legs was really, really painful, and it seemed more red and swollen than normal. And so he went to the emergency room, and he waited for hours and eventually left because he overheard one of the practitioners there call him a crazy Indian. And he waited till the next day when a resident of mine working with a preceptor who has a very good and established relationship with this community came for their outreach clinic there. And when my resident assessed him, he did notice that the limb was more swollen than the other side. It was very red. It was very warm to touch. When he did his vitals, the patient was hypotensive, so that means his blood pressure was quite low. He was tachycardic, so his heart rate was high, and he was feverish, which all of these symptoms are indicative that the patient was heading into septic shock, which is a life-threatening state from an infection, likely cellulitis of the leg. And it took my resident and the preceptor over a half an hour to convince the elder to go to a different hospital where they had admitting privileges and to be admitted through the emerge so that they could follow him and treat him appropriately with IV antibiotics. And it took calling on his children to be able to accompany him because he was so hurt and offended by the care he didn't receive the night before. And if he wasn't seen that day and sent back to the hospital, it's very likely he could have died. And so I share all these with you because systemic racism in healthcare and in Canada is very alive and real. And it kills my family members, it kills my community members, and it kills Indigenous people across the country every day. Just like it almost killed this elder. And that's why these conversations are important. And it's not something that is historical or that it's not current, but it's what we live with every day.
You are all 102 of you across the country are not able to sit here beside Terri, but I'm sitting beside Dr. Aldred, and we're both extremely emotionally impacted and affected. It takes a great amount of courage and bravery and strength for somebody who goes through a system, who has lived an embodied reality of that system, to share the kinds of stories that Terri has just offered you today. And I say that because part of the heart of this webinar this afternoon is to demonstrate that we will never be able to solve, so far as I'm concerned, as somebody who teaches in a faculty of medicine and conducts research in this area, we will never be able to solve the kinds of massive systemic health differentials and health discriminatory practices in this country through research and evidence and positivist, objective, quantitative knowledge alone. I deeply believe it requires stories. It requires a humanities-informed way of understanding this reality to affect change, to hopefully make things better. So we're now going to transition into some of the evidence and research that sits in tandem with the stories and narratives that Dr. Aldred has just shared with us. I'm going to move through this not slowly, but hopefully not too quickly, and tell you that what Dr. Aldred is sharing with us today is borne out in qualitative and quantitative study after study, in research evidence after research evidence, that we know that Indigenous people health status is impacted by anti-Indigenous racism in the healthcare system, both as a social determinant and as an access to care determinant. We also know from, as Terri shared with us, our own qualitative inquiries into this process, that Indigenous people are constructed and cast in very particular ways within the healthcare system. Terri's stories just illustrated an exercise that I do and have actually done through NCCAH webinars for years, where I ask family practice residents, where I ask participants, and here's what I ask: what comes to mind when I say Indigenous people, health, Canada? And I've done this with hundreds and hundreds and hundreds of participants across the country. The responses almost uniformly tend to be what Cree Elder Willie Ermine would argue is a consistently pathologizing construction of Indigenous people and Indigenous patients. If you say to yourself, what comes to mind when I think of Indigenous people, health, and Canada, rather than saying things like holistic medicine, amazing family physicians like Terri Aldred, humor, resiliency, amazing young people, international presence, land preservation, fortitude, and bravery, words like drug seeking, obesity, type 2 diabetes, tobacco, reserve, adolescent pregnancy, addiction, those are the words that come out of people's mouths when we ask people to speak about Indigenous people, health in Canada. And what I want to argue is that the evidence bears out that this kind of conceptualization of Indigenous people and Indigenous communities bears down on individual Indigenous people entering the healthcare system, be that as healthcare professionals, doctors, nurses, physiotherapists, psychiatrists, or be it as people interfacing as patients with the clinical system. That this system that is comprised of words and ways of thinking and the stories that are told about Indigenous people. I had a class of second-year undergraduate medical students just yesterday, and I was fascinated to hear this new word about high flyers. You heard that? Oh yeah, frequent flyers. They're high flyers. They're frequent flyers to the emergency system. There's already in second year words and languages to describe, often in northern communities, although absolutely in urban communities as well, mostly Indigenous people. They're frequent flyers to the emergency system. These are words that construct the patients that we work with, and they are words and stories that construct the environment that people enter when they're healthcare professionals, when they enter as medical students or as nurses. The power that words have to construct certain kinds of peoples and communities is an age-old settler colonialist strategy of constructing, the savage Indian that thus requires intervention through residential schools. The frequent flyer in the emergency system who then requires salvation or conversely requires being ignored. So these evidence are borne out throughout history and into the present day, which begs the question, and why many of you are here, well, how can this be changed? And of course, part of what we're arguing today, and as Terri has alluded to earlier, there are openings that are inviting change in the system. And thinking and speaking and doing and telling stories and making stories differently is in fact at the heart of, I would argue, practicing differently and providing better care for Indigenous people from coast to coast to coast. So, of course, the Truth and Reconciliation Commission, we are all operating and thinking and practicing in a post-Truth and Reconciliation, post-TRC time. The TRC is demanding that we think differently, particularly as non-Indigenous healthcare professionals or educators or clinicians, that there are intercultural competencies training, conflict resolution, anti-racism training. And that's some of the stuff that we're hoping to offer you today, is to encourage you all from coast to coast to coast to engage in stories and art. I was just in Edmonton recently, and I went to see the play Children of God, an incredible national theatrical movement offered through theater by an Indigenous director with an almost entirely Indigenous cast, talking about truth and reconciliation and the residential schooling system through the arts. So what we're hoping to leave you with today is really this sense that through arts and humanities, we can start to address the calls incumbent in the TRC. And by doing so, we can start to think and do medical and healthcare practices differently in this country. With that said, I really have to say that from my perspective, and this might be a question that comes up at the end of the webinar, I deeply believe it is not the place of non-Indigenous people to say when truth and reconciliation has been achieved. The moment I, as a non-Indigenous educator, practitioner, theorist, decide, oh, good, I'm done, my part of reconciliation is done, tick, good, I've achieved truth, is the moment that I really need to critically self-reflect, possibly through the arts, and think about how it is that if I am not understanding that each and every Indigenous person and community in this country feels that truth and reconciliation has been achieved, then the job isn't done. As non-Indigenous people, I think we need to check in consistently with ourselves, and I think that there's a role for arts and humanities to play in that check-in process to ensure that we are not falling into traps that have been fallen into far too many times before. We know that there was a Royal Commission on Indigenous people. Most of the recommendations have never been followed forth on, even though if you would ask many non-Indigenous people in this country, oh, were things sort of tidied up after the Royal Commission on Aboriginal People almost 20 years ago now? Many of us might have forgotten that it even exists. We're now on to the truth and reconciliation moment. So I would encourage us as non-Indigenous people invested in a time of truth and reconciliation who hopefully want to do better for Indigenous people from coast to coast to coast, to never think that our job is done just because we have a ticky box and think that it is. And that indeed the very languages that we are operating in help possibly perpetuate problematic orientations to truth and reconciliation. Did you want to add anything about TRC, Terri?
I think the Truth and Reconciliation Commission, like for whatever departments you're in, whether or not this one or this talk is in particular about health, but there are clear recommendations for things like education, justice, and health. And so even if you don't have the time or resources to go through the whole TRC report, and they even do highlighted summaries of the key recommendations for each major system in Canada, and to go through the health ones in particular and just familiarize yourself with some of the key recommendations. And some of them are very easy and simple to implement and are great starting places. So it's not this huge daunting thing that can't be done. That would just be my encouragement.
I think the other thing that the TRC is calling upon Canadians to understand is that there are an incredible number of Indigenous knowledges, Indigenous languages, Indigenous ways of thinking and being in this country, that it is incumbent upon Canadians, non-Indigenous settler Canadians, to really understand in a more depthful way. Terri, when we first began this webinar, encouraged us all to become familiar with the lands and the territories and the peoples who were here from time immemorial, tens and tens of thousands of years before the arrival of non-Indigenous settler Canadians, that we understand and check in with ourselves about knowing that land and knowing the history. I'm going to offer another more sort of humanities-based challenge to you all, and we'll just take 2 minutes just for the sake of conversation. And I'll ask right across the country, try to think of the name of an Indigenous artist, musician, author, chef, designer, somebody who has been generous enough as an Indigenous voice to offer onto the public record, if you can. Maybe your grandma is an Indigenous artist and you know her name, so of course put that down. But for those of us who are non-Indigenous Canadians, just for a moment, try to think of an Indigenous artist, musician, author, somebody in the arts and humanities whose work you've engaged in recently. If you guys want to type that into your question and answer bar, you're really welcome to. Oh, we've got lots of questions. Yes, Thomas King is coming up. Lee Miracle, Buffy St. Marie, yes, Norval Morrisseau, Kent Monkman, Kent Monkman, Jeanette Armstrong, amazing, amazing poet and storyteller. Billy Ray Belcourt, I don't know who Billy Ray Belcourt is, do you? We're going to learn things too. Leah Dorian, Tanya Willard. These are names that I don't know. So this is amazing. Maggie Kovacs, I know. Total. And Christy Belcourt, amazing. Rita Joe, yes. Amazing two-spirited poet, Billy Ray Belcourt. Oh, cool. Okay. Tanya Taglick. Did you see her in concert?
I haven't, but I have her album.
It's amazing. Georgina Lightning.
Cardinal.
This is amazing. Shelley Nero. Oh my goodness. I love Shelley Nero's photography more than just about anybody else in the world. Richard Van Camp. Yes. This is amazing. What we've just done, I think, from coast to coast to coast, and for those of you who weren't able to sort of right off the top of your mind come up with the name of Indigenous artist or musician or chef. I was just actually reading about an Indigenous chef. Yes.
Cooking with the Wolfman.
Yes, that's exactly right. I'd never heard of this before, and it was just awesome. But what I'm arguing, and what we'll go into in a little bit here in the next 10 minutes or so, 5 minutes, is that there's this incredible plethora of strength and resilience and creativity that if we engage that actively in this country as health educators, as clinicians, as health advocates, as people interested in social justice and anti-racist work, as people interested in cultural humility and cultural sensitivity, if we engage artists and we engage authors and chefs and musicians and designers and all of these amazing Indigenous voices that are offered up to us on the public record. I literally think it can shift the stories that we tell ourselves and our students and our residents and our future researchers about the way to think about indigeneity in this country. And I would hope that it can move us past some of the terrifying racist terrains that are out there that Terri began with through her stories. So for those of you who couldn't come up with the name, you now have a plethora of names. Oh, we've still got people pounding the names out. This is so awesome. I'm going to keep this. And I think we do have it on public record, right? Collate, is that the word? Yeah. Collate all of these names and this incredible resource that we've just come up with. So it'll be available for everybody to think about and have access to. So just for those of you who want even more amazing examples of Indigenous authors, this is Sarah, as you all know. I'm a poet and a creative nonfiction author when I'm not busily educating and working with undergraduate medical students and residents and producing research about Indigenous health and well-being in this country. I have the pleasure of interacting with Indigenous authors and artists from around the world and from Canada especially. So there are these amazing collections of contemporary Indigenous authors that I would really encourage you to think about and to access, to use as teaching tools if you are working with residents, if you're working with undergraduate medical students, or even in your professional circles. Think about starting book clubs and focusing entirely on Indigenous authors in this country. I'm gesturing back to Lisa Boyven's beautiful library of Indigenous knowledge, and I'm calling on Eve Tuck, who's an incredible Indigenous researcher out of the University of Toronto, who's recently put out a challenge, the Citation Practice Challenge, and she said, any research that we produce, any knowledge that we're putting out there, any information that we are trying to put on the public record, let's challenge ourselves to draw upon Indigenous knowledge holders, Indigenous stakeholders, Indigenous stories and voices. And folks, not in a culturally appropriating fashion, but drawing on words and stories and arts that are already on the public record. Let's think about reading these things. Let's think about these informing our practice. And if we want to really push some of the amazing boundaries of intersectionality, think about gender as it intersects with indigeneity. So think about Eden Robinson's work or Lee Maricle's work, Marilyn Dumont's work. Think about contemporary poets like Joshua Whitehead, who's two-spirited Indigenous poet, really putting out on the record sort of a non-binary voice of an Indigenous poet. People like Jordan Abel, who's a Nisga'a poet working in very contemporary experimental poems. These are the kinds of languages that I think can start to tear down the existing binaries and works of anti-Indigenous racism. I'm sorry that I didn't put Shelley Nero's work in here, because for the participant who talked about Shelley Nero, she happens to be one of my truly all-time favorite photographers in Canada, but she has worked with Jeff Thomas, who's an amazing Mohawk photographer who's doing really interesting contemporary conversations about racism in Canada, about historic racism in Canada, and also people like Susan Point, who's bringing back conversations about Tsleil-Waututh and Musqueam, traditional women's art and women's sculpture. Again, these are the kinds of artists and authors that I think clinicians and healthcare practitioners and educators can be incorporating into our health and healthcare and health system and practitioner modes of thought and modes of conversation. It is, in fact, out there, I would argue, to make healthcare in this country better for all of us.
Thank you for that. There's definitely a lot of names that came up that I'm definitely going to check out and add to my reading list. Not that it's not already long enough, but hopefully nobody's stomach dropped too much, because I'm going to start talking about some more positive stories and how we can move forward in a good way. So I actually met Sarah when I was a resident. doing a research project that all family practice residents in BC, but I'm pretty sure it's probably across the country, has to do in order to meet the requirements of their residency. And I thought that research wasn't my thing. I didn't want to do it. It felt like another hoop among all these other hoops that I had to jump through. And my program director at the time, who's an amazing woman, Dr. Danielle Ben-Smith, talking to me about it. And I had a really transformative experience when I was in Molokai, Hawaii, doing an Indigenous medicine elective. And she's like, why don't you do research on that? And I was like, well, that's not really research. And she's like, it might fall under story as research. And she connected me with Dr. Leeuw, and we had this amazing brunch where she's like, oh, why don't you do an autoethnography about your experience being an Indigenous physician undergoing ceremony in medicine? And I got to look up all these words like autoethnography and then Indigenous autoethnography, which is this whole other thing, and narrative medicine, and read some works from Dr. Rita Sharon. And it blew my mind. I couldn't stop reading about it, to the point where it was hard for me to write the paper because I just had so much information. And I was like, all right, this research I can get behind. And in particular, talking about narrative medicine and reflective practice, just as I called you to be kind to yourself, to pay attention to what comes up for you as you listen to this webinar, that's essentially what reflective medicine is in a nutshell, is being able to have moments in your life where you can take a pause and be reflective on what's happening. And so I reflected on a ceremony I did in Hawaii called Rebirth Mecca from a gourd, which is kind of like a pumpkin-like vegetable, but it's much more hollow and thin. And a Umeka was traditionally, it looks like a bowl or a water carrier, and it can be used for many different things. The message below that, the deeper, kind of more soul message, was it's a rebirthing ceremony. So as you do this, as you give birth to a Umeka from a gourd, you go through a transformation. And as you go through that with the gourd, transforming into Umeka, you start to remove and take away all the things that no longer serve you. And that when you birth it in the ocean, when you come up with your Umeka out of the water, you are clean, you are reborn again, innocent. And then you can use that Umeka to store things that come up. You can either write them down, or if there's objects, and you can keep them in there. And then at a fitting time, you can take them out, reflect on them, and let them go so that you stop being burdened. And for me at the time, this was in my second year of residency, so I was really close to being done. When I came out of the water, when I reemerged, what became very clear to me was like if the lens I was looking through things shifted ever so slightly. I realized that because I was of my wounded healerness, because of the racism that I endured during my training, as well as seeing an Indigenous people, I had so much resistance, and I needed to let go of that resistance and really embrace the fact that medicine was part of me now. I was a doctor, and as that, just like I was called from when I was a very young child to give back to my community, to have that sense of reciprocity, I now have that same responsibility to medicine, which, at the time was kind of like, are you kidding me? I really thought that once I was done my residency, I was going to run away, kicking and screaming, and never look back. And now, so close to being done, the Creator was showing me that, no, you have to give back. This is another area where you can pave the way. You can hopefully make it easier for those who come after you. And, fast forward 4 years later, I'm a site director and heavily involved in medical education still. But that ceremony was really critical for me. And when I went back to my rotations, and that, I was so much more unburdened. It was so much easier for me to learn and to engage. And, everything just felt so not burdened. I was suddenly less anxious and less depressed and less burned out. And I was like, wow, ceremony can really, really heal healers. Wouldn't it be great if we used Indigenous ceremonies in the Western medicine world for patients, but also for the practitioners? Because that's really what got me to a place where I could be like, I'm going to really apply myself. I'm going to really take in what I'm learning and really give it my all. It gave me the ability, the space, the health to do that in a good way. And so that's a little bit of how narrative medicine reflective practice really changed my journey in a really positive way. And so I started doing more ceremony in my day-to-day life, whether or not that's smudging and praying, doing sweats or cedar brushing, or up in North Central BC, it's more spruce bough brushing, or participating in a drum making workshop where I try my hand at poetry. I'm definitely not a poet like Sarah, but I can put words on paper sometimes, and that's the start. And I've started blogging and journaling and singing, traditional singing and drumming. And these things help ground me and remind me to show up in a good way that, you know, at the end of the day, all my patients, all the people that I see and touch, they deserve kindness. And kindness to me is the act of love. And when I'm cranky, and crankiness is like when I'm channeling negative energy, it's really hard to be kind. And ceremony gives me the space to be able to be kind. And for organizations, having the opportunities like smudging for people to participate in, like Central Interior Native Health did it at their weekly meetings, for instance, or if you do things related to Indigenous health, to not always focus on how it doesn't go well, like the rates of type 2 diabetes, but to have opportunities to explore the strengths. You know, if you have a book club, choosing an Indigenous author, an Indigenous story. If you have team building exercise, maybe see if you can have somebody come in to teach you how to make a rattle or learn a traditional song or do some traditional artwork. There's so many options out there, but to really explore the strengths of Indigenous people through their stories, but also through your stories, working with Indigenous people or being an Indigenous person, because this is how we can reclaim wellness together. And I'll leave with the story that for me, culture was what turned the light on for me. When it was so easy to deviate from my path, when I connected with culture, I could still get lost sometimes. The brush could still get really thick in my journey. But with the light on, it was easy for me to refine my way, to keep hopeful. And my kumu in Hawaii, Kumu Lawrence Aki, he tells it like this. He's a kumu pa'a, which is building a strong foundation. So they teach other kumus like kumu hulas and lomi lomis how to be healthy and well before they go out and do their healing work. And his analogy is of a lighthouse. So when you're in a position where you are a healer, and you may not be a nurse or a doctor, or you might be, but this could just be how you show up to your friends, to your family. If you're a manager, to the people that you lead, that you serve. And how you do that is you build a strong foundation. So lighthouses, if you've ever been to one, they have this huge, strong base so that they can weather the storms. And that base is self-care, self-wellness, because when you know who you are and you know how to take care of yourself, there's not a storm out there that you cannot weather, and you can be a light for others who are lost at sea.
I just have to interject before we move on and say, every time I have the honor and privilege of chatting on the phone or sitting down or doing something more professional with Terri, I kind of get sort of goosebumps all over my body and a kind of tightening of my throat. There's a really physiological response because she's a remarkably powerful, beautiful, creative person. And, you know, I'll share with you an example of this. She said that she met me when she was doing her residency, but I remember asking Terri to talk about the importance of the arts in healthcare environments, to what ended up being a packed audience in an art gallery in northern BC of healthcare professionals, clinicians, physiotherapists, dentists, undergraduate medical students, residents. And to my incredible amazement, Terri stood up on a set of tables. So she just got up on a series of tables and did a hula. there was 100 people in that audience. Everybody's breath was taken away. And I deeply believe it is in those moments when people's breath is caught and taken away through some kind of embodied interaction with creative practice that we can start to learn and start to unlearn centuries of anti-Indigenous racism or centuries of ways of wrongdoing medicine and clinical practice. So again, just to reiterate that the theme of this lecture is about the role of humanities and arts in unsettling colonial medicine. And I think everything that Terri is saying and everything I've seen her demonstrate over the years is an embodiment of that more abstract kind of academic title. I'm going to move a little more quickly so that we have time to have questions and answer conversations. But I think what Terri has just so perfectly demonstrated is, okay, the humanities and me. And what we're saying is that as clinicians, as Indigenous or non-Indigenous educators, practitioners, managers, people simply invested in conversations about health and well-being in this country, the humanities, art, ceremony, cooking, interacting with story, interacting with visual art, starting art-based interactive activities, these can all be done by us. We know in this country there's a call for clinicians and healthcare professionals, advocates, teachers to start thinking about social accountability. I think that that's at the heart of much of what we're saying. Again, I'm going to move quite quickly through this conversation because I want to leave time for questions and answers. But there is a world of research out there, like you even need to read it at this point. You've just heard Terri talking about it. So, go and read a fabulous book by Eden Robinson or by Richard Wagamese, as people from the webinar are suggesting. But if you are writing a scholarly paper about this, or you're thinking about putting it into curriculum, there is a lot of evidence about the humanities really connecting people with what it means to be human, with the human side of healthcare practice and medical and health practices. Again, Terri spoke about Rita Sharon inspiring her early on in her career through narrative medicine. Absolutely. Storytelling and narrative medicine is ascending in the conversations about ways to reimagine healthcare practice and healthcare production. There's just loads of information out there. I'm not a real believer in having to have the kind of scholarly evidence in order to, that's not the heart of the Lighthouse Foundation, as Terri was sharing. It's just a plethora of information by academics and scholars who are, if we need it, providing an opportunity to justify what it is I think many of us already know. Again, these models are available to you at the end of this lecture. So some really helpful in-practice things that you might want to take away from this, in addition to things like starting book clubs, engaging in ceremony, thinking critically about truth and reconciliation, going to art galleries and actively seeking out Indigenous presences, going to theatrical productions or watching movies. I just did a lecture last week with a Métis physician who graduated, actually, she's now down at UVic. And she suggested that anybody who hasn't seen the Netflix movie Hunt for the Wilder People, it is so great if you just need this completely fabulous, uplifting movie by an Indigenous Maori director out of New Zealand about the sort of terrors of child apprehension as a determinant of Indigenous people's health, but from a totally brilliant Indigenous knowledge perspective. Go and watch Hunt for the Wilder People tonight on your handy-dandy Netflix connection. It's well worth it. But other ways that you can apply a humanities-informed practice in your own lives, think about undertaking and actively undertaking creative, critical self-reflection. And there's a little diagram that I developed a while ago that allows you to kind of take yourself through critical reflection and critical journaling activities. Draw on the humanities as much as you can in your practice and your research and your knowledge. you might think if you are teaching in medical schools or if you're working with residents, to really let the humanities pop people out of rumination and move them into reflective spaces. We know that rumination is actually remarkably unhealthy to ourselves as clinicians, clinical practitioners, educators, or people involved in the healthcare field. For 8 years now, I've been placing in partnership with the First Nations Health Authority, the National Collaborating Centre for Aboriginal People's Health, and the Northern Health Authority, placing undergraduate medical students and residents into First Nations communities and asking them to go through arts-based engagements in order to think about future practice. So working in conjunction with communities to prompt arts-based and humanities-informed ways of knowing and being. So again, just student critical reflections, these amazing ways that students and future healthcare practitioners, in this case doctors, have used critical creative writing to reflect on positions of anti-Indigenous racism or non-cultural sensitivities. And again, we're going to move through this, but this is all available after this webinar wraps up. If you want to see voices of future healthcare professionals in action through creative reflective practices. These are photo opportunities that students have been engaged in when they're in small communities, working with profound health and well-being in Indigenous communities and reflecting on their interaction with Indigenous communities in a creative, reflective way. Photography and reflective writing to think more against anti-Indigenous racism in the country. Students painting with artists in communities, and again, in placing themselves and thinking through what it means to be a future healthcare professional in Canada, thinking with critical anti-racist lenses, thinking with cultural competency and cultural humility. I'll turn to Terri now, just to, I think, close us out in an artistically, creatively, humanities, and most importantly, Indigenous-focused way, and then we will take questions, hopefully, for about 10 minutes from around the country.
I think maybe we should ask a couple questions and then we can end with the story will take like 1 minute. So just to make sure we have time for questions, I can abridge stories pretty good.